So this haloperidol and promethazine, screen change हो रहा है ये वहाँ पे zoom. So haloperidol and promethazine, we say that this we are giving, but as per the level of recommendation, which might change, lorazepam IM and olanzapine IM. You know, few of the patients we have given them olanzapine IM and they responded very well, but I don't know when it didn't pick up. Availability also is an issue. So when we say acute mania, so acute mania, many a times, you know, patients, they are given, many a times patients are given this antidepressants like escitalopram and clonazepam combination, and they treat it as a hypnotic, and they say that नहीं नहीं ये दे दीजिए हमको, हमने ये patient को खिला रहे थे, थोड़ी सी नींद आ रही. So in that context, discontinue any antidepressants, and you have to treat comorbid substance use disorder in case of acute mania. So and when we talk about therapy, we talk about monotherapy and polytherapy. When we talk about vis-a-vis epilepsy, so when we see, this is an algorithm, little difficult to remember, but you can always, you know, refer CanMed for this. When we talk about mild to moderate mania, we go for monotherapies. Monotherapies like lithium, Qutipin, Divalprex, Sinapin, Aripiprazole, then paliperidone. These are level 1 for paliperidone, level 1 for dosages more than 6 mg. Then risperidone. These are all clubbed together, and then subsequently carbamazepine, olanzapine, ziprasidone, haloperidol. See, CanMed is the one of the few guidelines which gives you level of evidence on the basis of efficacy and tolerability. So that is why olanzapine comes on second line. But is one of the favorite agents. We use it quite a bit, but subsequently find that it is full of side effects also. So when we use lithium, you can see the first line, lithium is there, Qutipin is there, Divalprex is there. So when we use anti-epileptic mood stabilizer and lithium mood stabilizer, those response specifiers are pretty fixed and pretty, they're vividly immunotextual. So lithium we use when there is a euphoric mania, first episode is mania, this family history of mania or bipolar disorders, then past history of response to lithium, and a steroid-induced mania. Then when the psychotic element or schizoaffective picture is there, don't refer mania, because lithium, then you have valproate and other anti-epileptic mood stabilizers take preference. Any other? Any other specifier?
Family history.
Family history. So how long to wait? Now, supposedly we are treating mild to moderate. We can't wait in severe cases. This is about mild to moderate. How long to wait for giving a treatment? So 2 weeks. At least 2 weeks we shall wait to see whether given the treatment is getting, the response is getting. Supposedly I am giving Qutipin to a patient. I need to, and by 7 days the data says it differentiates active and placebo response. At least 7 days to rukna hai. 3 days, 4 days, we can't shift on switching of drugs, which at times we do it there because of the lack of, because of the pragmatism involved here, because of the patients, they run out of the time to go for polytherapy, which is at times not evidence-based. Then severe manic episodes, combination. So you have to, that is why you have to grade it, how graded mania is. Generally, patients who are admitted with mania, unless there are other contextual issues involved, they are severe in intensity in our context, on our setup here. So combination therapy of lithium or valproate. So lithium or valproate with SGAs. Any SGA you can involve here. You can actually subsequently do it. Now, if there is no response, then what? This is a challenge. Then we need to get it correct. This is a challenge. So if there is no response, what do you do? Because this is not given in any textbook. So, you know, after logging it up to date is one of the vehicles, a database which collects the information and puts it, and it's a reviewing kind of a database. So I've got it from up to date. So up to date 2021, 20, the article was there. So it says switch the mood stabilizer to another one if there is no response. So we'll not switch the antipsychotics, we'll switch the mood stabilizer. Generally, we do it here, or we add one subsequently, so lithium to valproate or vice versa. If there is no response, Change the antipsychotic in the combination. ठीक है, नहीं response आएगा तो change the antipsychotic. If no response, so ECT हो गया, दो हफ्ता मिला के 6 हफ्ता हो गया. So maybe we go for ECT. ECT indication here becomes non-response. So here then we give ECT because of the non-response. Then if no response, then we add lithium valproate plus fluoroquine. But mind you, this is from up to date. They have actually assimilated their own review. And the reference, the valid reference is there. So then they say that you actually add clozapine if the patient is having ECT non-responsive bipolar disorder. The mixed features. The patient is having mixed features. There are a lot of female patients that admit here. The mixed features, they say that you use divalpress with second generation antipsychotic. Second generation antipsychotic in mixed features, they say that it's a class effect. Negative studies. Now this is important. What not to give or which might not work is adding ziprasidone to lithium or ziprasidone to valproate. Then carbamazepine with risperidone or olanzapine. So this won't work. Yeah, personally, I think we would have given a lot of patients carbamazepine and valproate if they don't respond, but the data doesn't support the combination here. Then coming to rapid cycling. Rapid cycling is more than 4 episodes per year. What to do? Rapid cycling, this is important. We have to avoid antidepressants, avoid stimulants, rule out hypothyroidism, and rule out any subclinical hypothyroidism. Then response to psychotropics is inferior to non-rapid cyclists. So this is important. Then weekly follow-up until the response. So we have to follow them up weekly. So rapid cyclists, because of this rapid cycling, you can't give them a follow-up of a month or so until unless there are other factors involved. So weekly follow-up as per the NICE guidelines. Then continue the regime till 2 to 4 months. And a longer regime need to be continued. Because of the refractoriness, we need to wait for a longer duration of time for the response to come up. Maybe that kind of a psychoeducation patient needs in that context. Then now, previously they used to say that valproate is better than lithium in rapid cycling. Now they have brought out this data that there is no evidence of any superiority of any first-line agents like lithium or valproate. So, but as expected, combination therapy will be chosen than monotherapy. Then refractory rapid cycler. Everything you do, nothing works out. Then there was a data which came up that supraphysiological dosages of thyronol or altroxin needs to be given around 50 micrograms. Then clozapine might be added. जैसे आपका एक acute mania में जो rapid जो आपका refractory acute mania में phases थे combination therapy के बाद भी patient are not responding, you go to clozapine or ECT. So that is how the algorithm and the treatment approach goes on. Negative lamotrigine. A lot of residents we ask this question whether अगर मान लीजिए रैपिड साइक्लिंग है तो बहुत लोग रैपिड साइक्लिंग डिप्रेसिव फेज में लैमोट्रिजिन ऐड कर देते हैं. बट अगर रैपिड साइक्लिंग पिक्चर आ रही है डिप्रेसिव फेज में पेशेंट प्रेजेंट कर रहा है, लैमोट्रिजिन शुड बी अवॉइडेड इन prophylaxis of because it has negative studies. Now coming to acute depression. Acute depression, antidepressant monotherapy is enough. So patient comes with depression, you have to make all your efforts to tease out any indicator of bipolarity or any past history of any mania which is missed out in a heavy OPD. So that is probably criminal. So we need to see it very difficult in female patients because at times the presentations are mixed. You know, many a times patient is having a mixed picture in front of us, we miss it. So how to tease it out in history becomes very, very difficult. So that is why history is very, very important in psychiatry. That is why at times we lose patients, you know, when people evaluate cases in OPD, because we want to historical significance of मिल जाए, patient we clarity में मिल जाए, then we start with the treatment. So now acute depression, the treatment approach varies with two questions which can be very vividly posed. If there is a need for rapid response, then if there is a need for rapid response, we'll give fluticin as a first line, less than 300 milligrams. Lurasidone, first line, ECT, and olanzapine fluoxetine, they put it as a second line, but equally effective, but second line again because of the side effects of olanzapine. Then, when we say slow response, so lamotrigine till 200 becomes the first line because it requires slow titration. And lithium also, lithium levels till 0.8 to 1.2, it is again first line as per step BD, but onset of action is 4 to 6 weeks. So acute depression है दोनों काम करेंगे बट स्लोली काम करेंगे. So we need to see a question, and no patient will accept the option of slow a slow response. Very few patients will accept that. Everyone in bipolar depression, they comes with a lot of I would say morbidity, so they would require a rapid response. So generally what we do is we combine this. हम लिथियम भी दे देते हैं, थोड़ा कीटन भी दे देते हैं. अच्छा, अब रिस्पॉन्स नहीं आया तो हमने 2 वीक्स वेट किया, ये रिस्पॉन्स आया. तो अगर लिथियम लैमोट्रिजिन है तो स्लो टाइट्रेशन करेंगे, वहां तो वेट कर सकते हैं. अगर बाद में उसके बाद भी रिस्पॉन्स अगर नहीं आता है तो वी गो फॉर कॉम्बिनेशन थेरेपी. और वी कैन ऐड वैल्प्रोड. वैल्प्रोड हैज डोंट इतना एक रोबस्ट डेटा वैल्प्रोड साथ है नहीं. In any case, if you vouch for us or sir says कि नहीं, I would give antidepressant. So this Megger et al. It came up with this concept. It's a part of step BD only. That 15% of the subset of patients will only respond to antidepressant. आप कुछ भी कर लीजिए, कितना भी antidepressant अवॉइड कर लीजिए, उस पे ही वो रिस्पॉन्ड करेंगे. वहां पे आपको SSRI देना है, न्यूट्रोपियन देना है. SSRI कौन सा दे सकते हैं? Which is the minimum switch potential SSRI? ठीक है, बता देना. ठीक है, ketamine small trials used for fast response to depression. Ketamine is more of an euphoric. It brings euphoria in a patient. So ketamine, but the long-term data we don't have. So again, it has not come in the guidelines still now. That is why. But surely it takes care of the active suicidal tendencies. But it has to be given under a mood stabilizer. That is very important. Mixed features again, like like acute depression. If there are some indicators of many features like racing thoughts and all, you avoid antidepressants. And SGAs have a class effect. Class effect like SGAs will, the action is better than any other class like FGAs or mood stabilizers if we talk about mixed features per se, like lorazepam and olanzapine. So you just forget this block. Melancholic depression आ गया. Patient goes into severe psychomotor retardation, doesn't almost we feel that patient is into a catatonic phase or severe psychomotor retardation. Melancholic bipolar depression, ECT becomes a very good option. Now क्या नहीं देना है? This is important. Heliperazole doesn't act in acute depression and bipolar. And we used to give before Gambit. And we thought that it responds, but negative studies are there. And ziprasidone. I don't know whether Canmet has something to do with ziprasidone or ziprasidone was not done. Ziprasidone has come in a lot of negative studies. Now coming to maintenance phase. Maintenance phase, maintenance phase we need to give treatment. Why? So what the next cycle? Need to reduce the recurrence as per your answer. Any other reason? Bipolar disorder can be neuroprogressive. आपके 5-7-8 episode के बाद the episode might not even get remitted, and patient might develop cognitive deficits. And vis-a-vis schizophrenia, which we say after a point it gets neuroprogressive, dementia, bipolar disorder subgroup can be neuroprogressive. तो कौन-कौन सी conditions हैं जिसमें ये risk होता है? That is younger onset. Psychotic features. Almost it appears to be a schizoaffective kind of picture. Rapid cycling, more than 4 episodes in a year. Severe comorbid anxiety, which doesn't respond to conventional bipolar treatments at all. At times, substance use disorders, persistent poor inter-episodic recovery, and despite all of your efforts, CBT, psychotherapy, regular counseling, regular follow-ups, residual symptoms. So, SMA, there is an inkling, and most of the patients we now see here are from referred from other places, and they are not very easy bipolar disorder patients. So, guidelines are getting. So Canmet guideline कहता है every episode should have a maintenance. ठीक है? European guidelines कहती हैं after second episode, if less than 3 years between the two episodes. So अगर 3 साल के अंदर दोनों episode आ गए हैं, so we need to give an European, you need to give a maintenance treatment. And World Federation of Social and Biological Psychiatry (WFSBS) guideline, which is a very very famous guideline, it says, first episode you can give maintenance treatment if the symptoms of severe and family stays positive. Second episode you can give maintenance treatment if symptoms are severe or family stays positive. And third episode, any third episode. So gold standard क्या है? Bipolar disorder क्या maintenance treatment. So bipolar disorder means patient is currently not having any acute episode. Patient has gone from acute phase We want to give something to prevent that. So gold standard is lithium. It will prevent both mania and depression. So again, clinical indicators of good response to treatment to lithium are similar to those response specifiers of anti-epileptic mood stabilizer. Lamotrigine is good for prevention of depressive episodes. I'll come to this later on. Then Q-tipin prevents mania, depression, and mixed. So Q-tipin is again 4x4. We say all the 4 phases which mood stabilizer acts. So lithium and Q-tipin. Then when we talk about this series, so CanMed has put this series that lithium, Q-tipin, valproate, lamotrigine, aripiprazole is better than olanzapine, risperidone, long-acting, and carbamazepine. What doesn't act in depression? Maintenance is aripiprazole. Again, so aripiprazole acute depression में भी काम नहीं करेगा, maintenance के depression में भी काम नहीं करेगा. And risperidone long-acting maybe because of the side effects or the efficacy they didn't find. So what to do? Start lithium, ठीक है, नई response आता है, we add valproate in bipolar 1 disorder as per balance study which was a very famous study. So at least अगर मान लीजिए patient respond नहीं कर रहा है, हम lithium देंगे, हम उसमें valproate add करेंगे, उसके maintenance phase को थोड़ा सा proper ले जाने की कोशिश करेंगे in bipolar 1, not in bipolar 2. Bipolar 2 में lamotrigine will come into the picture. Psychoeducation becomes important because it is the most evidence based. I think so there's few two models and which is better than CBT, family focused therapy, and IPSRT is third line. And we have not discussed this in acute phase. Why? Because acute phase it doesn't work. From maintenance phase, psychotherapy works. I think sir, this is 9:30. Shall we continue or we'll continue later on? Because there are 3 more sections. Break it in 2 parts and we can discuss it and then maybe 25 minutes have already gone. So we'll continue this in 3 parts. So now ECT suicidality, then women and bipolar disorder. 1 section is there. Then child and bipolar disorder, and geriatric bipolar disorder. 3 sections are 4 sections are left, which we can subsequently discuss in the later section or next week or on 23rd. I think Tanya is not there. 23rd we can do it. Okay. So any questions till here? Because this is something which is very important. Any questions from the audience who are joined online? कोई confusion, किसी प्रकार का कोई clarification? Because this is something which is as per purely as per CanMed and there are some other references. ISBD is one more. Then up to date. Up to date is a very good forum. Elsevier is bringing up similar forum as up to date for Indian population, for Indian students. Because anything else? Discondition syndrome.
Like if there is non-compliance with
actually the episode will relapse, the comeback very quickly if you don't taper the lithium. Because if supposedly patient is having CKD and we have to stop the lithium, they said we have to stop it, at least taper it in 2 weekly or at least in a month, so that relapse doesn't happen. Like in case of toxicity, you can't help the patient, that day 2.1 level came, so we have to stop the patient lithium. But then it can be a risk the patient might have another episode. But in that context, we have given second mood stabilizer or third mood stabilizer. In that context, we are already preventing it. Discontinuation syndrome is common, and at times they say that when we abruptly stop lithium, the response to lithium also gets compromised in subsequent episodes. So you need to discontinue it under clinical discretion. But rapid cycling is a challenge. We all do a lot of things. Then bipolar disorder is a bipolar disorder because obviously these guidelines, these some directions to do a treatment. They are not enough in many patients. And many clinicians are giving a lot of ECTs to the patients in very early stages, and then probably they are becoming more refractory to response. They're seeing it here also.
A lot of questions about lithium because lithium studies have reduced. Lithium is a very good antidote, but because of coming of SDAs and others,
Yes, sir.
we find that it is also losing popularity in the clinicians, and studies are also less. There are many unanswered questions which still are unanswered.
And lithium is being taken up by stem cell transplantation people because it increases hematopoiesis. They are giving it now. Okay. They actually once occasionally they call us and ask us how to give it, how we dose it. So I think that there are some more sections. Lithium and thyroid is one more thing. We have a presentation. We can make also, because that is very frequently asked question. It's very confusing area. Okay, thank you. I'm ending the presentation.